Thank you for the introduction. I'm János König from the Department of Prosthodontics, and I would like to introduce to you my PhD topic about treatment possibilities in oro-maxillo-facial rehabilitation. My vision is to create a whole new environment in maxillofacial prosthodontics, since currently the procedures that we are doing on a daily basis are improvisative and not evidence-based. So we need principles that and protocols according to this evidence-based principles. And my mission is to assemble a team that is able to treat these patients with adequate funding, and I would like to lay the foundations for proper scientific output. These are the first small steps for achieving that mission. My first project is about 3D facial scanners. And this can be usable when we would like to make an artificial nose or artificial ear for a patient. For example, this patient on the upper picture requires some restoration of mid-facial structures, such as the nose, the upper lip, some parts of the cheek, and of course the hard palate. And the first step of fabricating such appliances, we need an impression of the patient's face. And currently, the traditional facial moulage impression is the current method for obtaining that. And the main disadvantage is the capture time, which can last for 15 minutes at least, and the breathing obstruction, because during the setting time of the impression material, the patient cannot be breathing through his or her airways. So imagine being stuck underneath that pile of impression material for that long. So facial scanners are a viable alternative, or seems to be a viable alternative for that, since they are non-contact and they are much more faster than this one. But for clinical usability, since there's no designated scanner for this specific purpose, we need to assess the accuracy first of scanners that are from other industries. And for that, we would like to perform an accuracy analysis on different facial scanners in different facial regions. And for that, we would like to compare these interlandmark distances and interlandmark angles that is measured directly on the patient's face, and later it is measured on the virtual model on a computer. Our hypothesis is that there will be no differences between scanning technologies and between facial regions. And if it proves to be an accurate method, then we get a reliable and comfortable and, most importantly, safe method for the impression taking of the face. We've conducted a systematic search in 5 databases, and at the end of our selection, we get 27 eligible articles. And currently we are at the stage of the data extraction. The second project of mine is about rehabilitation of patients with maxillary defects. These defects are a result from oncological treatment, meaning that after this ablative surgery, the patient is cancer-free, but the quality of life of the patients are usually decimated. So we need some kind of rehabilitation, and the point is that more and more patients are surviving head and neck cancer for longer and longer times. So we have 2 options: the surgical reconstruction and the prosthetic reconstruction. And the choice in between those 2 arms of treatment is still controversial. It's heavily reliant on the operator. So our aim is to compare all the commonly used solutions as for their therapeutic effect goals. And since there are so many possible interventions, we have made a map, and you can see that at the center there's the so-called conventional obturator dentures, which can serve as the common comparator for our PICO framework, and the I stands for the different restorative surgical and restorative prosthetic interventions. The outcome measurement would be the quality of life, which is a patient-reported outcome, but this is standardized via 2 commonly used questionnaires. and we would like to include articles that are using these two questionnaires. A null hypothesis is that there will be no differences in quality of life. So, given that the prosthetic options, the prosthetic treatments are less costly and much faster to do and easily modifiable, if they offer the same results, then this can be a more effective and more better option. My third project is about almost the same topic, but it focuses on soft palate defects, and believe me, soft palate defects is much more interesting than hard palate defects, because they cause valopharyngeal insufficiency, which makes the patient not able to talk and not able to swallow, not even their own saliva, so they are always surrounded with wet tissues. And the main option of treatment is speech therapy, but given that the speech therapy only enhances the muscular coordination, then in cases that the whole soft palate is absent, then it's not an effective method of treatment. So it is often supported with surgical reconstructive methods and prosthetic methods, but prosthetic methods are quite neglected, so not even prosthodontists are aware of the fact that this could be an option. And this is due to the fact that there is no accepted protocol for the fabrication of such appliances, so we need to establish that. But first, we need to prove the non-inferiority of such prosthetic appliances. And the PICO is almost like the same, but we excluded cleft patients because cleft patients are treated with strict international protocols, and the outcome is measured through speech intelligibility, because that's the most objective way of assessing the status of these patients. And if it proves to be these prosthetic interventions that has the same results as the surgical intervention, but less cost and burden, then we get another better option. And I would like to make a proof of concept study of the fabrication of soft palate appliances with both the conventional way and with the conventional workflow and the semi-digitalized workflow, because the question is that whether it is feasible or not, this blue workflow, or is it being any time or cost saved, and is it more convenient for the doctor and more comfortable for the patient? And I would like to thank you for your kind attention, and I brought a quote from Tibor Bödöcs, which cracks me up sometimes when I feel that everything what I do is not that important. Thank you.
I have one. In the first study, you presented 26 papers selected for the analysis. How many types of scanners were in these papers? Would it be something you can streamline to one type, or there will be quite a wide range?
Well, I would like to perform a subgroup analysis because there's three main options of three main technologies that is currently used for surface scanning, which is namely the stereophotogrammetry, laser scanning, and structured light scanning. And if I have the sufficient data for this subgroup analysis, then I will perform that. Otherwise, only one technology would be included in the statistical analysis.
Thank you.
So I just want to ask the question for project number 3. So you were planning to compare the surgery and complement therapy, right? So how long it will take to get improvements for these patients? So does this patient requires any kind of psychological advice from doctors, or because the patient has to be more patient, right, in order to get a good result? And so
yes,
maybe doesn't it feel like it's better to get a surgery instead of this long term of effects? Just want to know your idea. Thank you.
So it requires a multidisciplinary treatment, and this is lacking in most of the countries. Most of the countries on the world, so it's still controversial that which treatment protocol is the best for the patient, or which is working even.